who's not doing it?
I'm surprisingly happy about the locks.
Hello, sorry, I've seen your text, but yes, please feel free to start. That's fine.
Hi, Zoe. Hi. Sorry.
Work. So yes, feel free.
Can I start the sharing? Hello. Zoe, can you hear me, Zoe? Yeah, and we can start now, right? Okay. So, good afternoon, everyone, for this journal club. I'm not going to take much time, but it's a very interesting topic to talk with. So, I'm just discussing about a topic on a journal paper called ITACTIC. It is basically you're trying to compare your conventional coagulation test with your viscoelastic hemostatic assay, which is the TEG or ROTEM, to see which has got a better in terms of treating the hemorrhagic shock patients, mostly in the traumatic scenario. So the most important question they're asking is that a patient who's presenting with hemorrhagic shock in a trauma situation, is there any difference in terms of patient mortality or in terms of massive transfusion? Is there any change which is going to be implemented with these testing? If you look at the background, nowadays we've been starting to use VHAs more commonly everywhere in the trauma centers and bigger hospitals. We've been starting to use TEG and ROTEMs. Again, there are a few Cochrane reviews in 2016 which clearly says that VHAs have got a better in terms of improving the mortality and reducing the need for the blood products. But in terms of trauma, we don't have a much higher RCTs to prove that. In terms of outcomes, this paper looks at the proportion of live patients after the transfusion and also looking at the patients who are free of massive transfusion after 24 hours. Secondary outcomes, there are multiple secondary outcomes they're looking at it. Nearly 19 to 20 outcomes been looking at it. But I've just grouped out few outcomes which are very essential, like the cause of mortality at later days, total blood components used, ICU-free days, and ventilator-free days. In terms of design, this is a randomized multi-center trial. This is randomized in the ratio of 1:1 with block randomization, and multiple secondary outcomes have been looked in. One important thing is the treating teams are unblinded, so there is a possibility for a bias in this because of this unblinding. And consent has been got from the patients in an appropriate terms, and independent data monitoring has been set up as well. In terms of setting, it's been conducted in nearly 7 major trauma centers in Europe, and between 2016 and 2018, nearly 2 years, and it's been published in 2020. Inclusion criteria, they're looking at trauma patients who's in hemorrhagic shock, who's got a shock index of more than 1, and patients been within 3 hours of injury or at least 1 hour after the admission to ED. And they're looking at the patients who's got a major hemorrhagic protocol activation and red blood cells are transfused. Exclusion criteria, anyone who's not fitting into this criteria has been excluded. But you look at the numbers, they have screened at least 1,300 patients, and they're able to randomize around 400 patients and 200 to each group, out of which few patients been left alone because of lack of consent over there. So most of the patients are treated with an intention to treat analysis technique. Other variables, they looked at the demographic variables, injuries, and the physiological variables. Most of the variables are same in both the groups, but if you look at a few variables, which has got a bit of significance in terms of the limitation of this paper, which I will discuss later. Looking at it, you can clearly see prior oral anticoagulants, the percentage of patients involved in the study is 8% and 6%, so they're very low in terms of analyzing the effect. And in terms of blunt injury, more than 2/3 of the patients are blunt trauma patients. So we don't know about the impact of the study in terms of an penetrating injury patient or patient who's had an surgical bleeding. Intervention, so they divided into intervention group and control group. Intervention group will be using a VHA technique like either a TEG or a ROTEM. And the VHA test, once it's started, we can eventually start giving the treatment, like starting with the products without wasting the time. Control group, they have to go for the coagulation testing and they have to get the results, and based upon that, the products are replaced. How are they replaced? These are the protocols they'll be using. On the left side, you get tabular column A, which is the ROTEM techniques, which is using either FIPTEM or XTEM values to look for which products you need to be looking for. And the middle column is the TEG. which is again using your R values, MA, and K values to see which is abnormal, and they can supplement with their blood products. The last column is the conventional test, which will be looking at your fibrinogen levels, platelets, and INR to transfuse the products. Management protocol, all the patients, they receive the major hemorrhagic protocol at the ratio of 1:1:1, like packs red blood cells is to platelets is to plasma. Again, we moved away from the crystalloids as due to the increase in the coagulopathy, and all interventions are scheduled at the right time as scheduled in the study. Outcomes, they're looking at the primary outcome. If you look at the outcome at 24 hours, there was no significant difference between these two groups, and the proportion of the patients who are alive after the transfusion is nearly around 67%, versus 64% in the VHA versus the CCT group. And you can clearly see that the odds ratio is more than 1, and the confidence interval is crossed 1 as well. Secondary outcomes, I've not mentioned all the secondary outcomes because there's no significant statistical difference, but I've just focused on few outcomes which needs a little bit look on it. If you look at the subgroup analysis, they have looked at the traumatic brain injury group of patients where the mortality is significantly reduced with VHA group, but with the CCT group, it is quite high. I don't know whether it is because of the time to the intervention is quite late in the CCT group, which needs a post hoc analysis as well. If you drill a little bit into the results, you can clearly see nearly 400 patients are randomized, and most of the patients are treated on the intention to treat basis. And very good thing is there was very fast randomization so that you can have a median time of intervention within 69 minutes as a maximum. If you look at the proportion of the patients alive or free of transfusion, so you can clearly see it's 67 versus 64% between the VHA and the CCD group. And if you look at the mortality, it's again similar in both the groups. And the person who has received who received a massive transfusion is nearly 20-25% as well. And remaining other outcomes, secondary outcomes, didn't have any much of the statistical difference. One important outcome you need to look at is the quality of life. They use the EQ5D protocol to look at the quality of life at 28 to 90 days. And if you look at it, the CCT group has gotten the best value when compared to the VHA group. Even though the numbers are not that significantly different, like CCT has got a value of 49 with the VHA group of 40. But again, clinically, it is much more significant. Again, the same things applies in the adverse effect as well. There's a 10% absolute reduction in the thrombotic events in the VHA group when compared to the conventional test group as well. Even though this is not very significant in terms of statistical evidence, but clinically it is much more significant. And most of the studies nowadays, they more focus on identifying the efficacy than identifying the adverse effects. So they're very underpowered in terms of identifying the adverse effects. 28-day mortality, again, you can see both the groups didn't show much difference. And even the odds ratio, you can see it's around 1, and confidence interval is moved towards 1. So the final conclusion is they're saying that even if you use a VHA or CCT, when you're treating these patients, there is no improvement in overall outcomes. That's what the conclusion is. If you look at the strengths, this is a multi-center randomized clinical trial, and it's answering an important question because in trauma management, the time is very precious, and again, blood products is again a precious a treatment as well. So we need to be aware of when we use those blood products, we need to use it very wisely. They have wisely used the prior data to identify the sample size. They've used both intention to treat analysis and protocol to per protocol analysis to find the primary and the secondary outcomes. Very good thing is about the randomization. It was very quick from the median time of around 60 minutes. And most of the baseline characteristics are mostly matched in both the groups. Again, there are a lot of limitations which is seen in each of the studies. Again, it's not to criticize, but just to see what are the things we missed in this paper and which we can overcome in the next studies. Unblinding to the treating clinical teams. So problems are like if you're unblinding it, physician who's more favorable towards or has got a good practice with VHA will be more leaning towards a VHA practice than a CCT dependent blood transfusion. A very few patients in the trial had baseline coagulopathy, so we are not very sure whether these patients are really coagulopathic and is this treatment making a big difference in it. So that's again one of the limitation. And also, if you look at it, the patients were on oral anticoagulants. It was around 7% in both the groups. So again, that's a big question whether these group of patients will they be beneficial with VHA or CCT. The study was performed in larger trauma centers who's been using VHA on the day-to-day practice, but again, because of this, it's basically losing its external validity. So I don't know whether how we can translate into other countries and other hospitals where even they just do have only 2 or 3 units of O negative blood. Just giving those 2-3 units will be a massive transfusion for them, and they would have not seen or used the VHA into practice. So it clearly lacks an external validity translating this result in the other hospitals. Next important point is the traumatic hemorrhage. If you look at it, traumatic hemorrhage, we can clearly see that a lot of surgical cause for the bleeding as well. Those group of patients were not highlighted in the study, so we are not very sure how is it going to be beneficial for them. One important thing is in terms of the data, what they have used, have they received it from the TEG or ROTEM, which hospitals have been using it? There's not been much data on it. Baseline differences, they're not much adjusted, but overall, the baseline characteristics were same in both of the groups. So the take-home message is, in terms of the traumatic hemorrhagic shock, would you use a VHA or CCT? The study says no benefit, but clinically, I would say I'm still leaning towards a VHA than a CCT due because of the time interval. With the VHA, we can quickly start the treatment and start giving the products, whereas in a CCT, we'll have to wait for the results to come back. Again, does it make any difference in the mortality or patient free of transfusion? That's a big question, which further studies needs to be addressed. But I think it's not going to make a much big difference. But we're waiting for further studies in future to tell us whether VHA is still effective or not. Thank you.
Thank you very much.
Is there anything? I hope that was.
Does it change or confirm anything that we do you think?
I don't think so, because it clearly says that there is no significance in terms of any outcomes. As I already said, that maybe we'll be leaning towards the VHA because we have a very quick time interval of obtaining the results and starting the products, which has not clearly shown any improvement in the outcomes, but we lean towards this as a clinician because we always look for any clinical significant outcomes than a statistical significant outcomes.
Yeah, I mean, outcomes of kind of quality of life, it doesn't feel like it's that's going to make a huge difference to it. It's more how long they're in hospital and in ICU, and rather than, which I guess the amount that you bleed will affect, but yeah, it feels like it's more related to blood loss at the time and hypothermic acidosis.
I think one important thing is like maybe again, this study has clearly not shown us like whether the patients who've been involved in the study are really coagulopathic or not. So that again needs further studies to tell us whether that will be very helpful in those group of patients. So, but I think I still will lean towards VHA than CCT.
Yeah, I think most people do. I think when I suspect it hasn't changed, but when I was at Glenfield, they do. You have somebody feeding you up, and they get a round of products regardless of what the tag says anyway. They've got a normal tag, then they still get a load of stuff, which didn't feel that logical in my head, but it usually made the bleeding stop. But whether that's just time or whether that actually has an effect, I don't actually know.
Yes.
There's nobody on to tell me what they still do. I see they
I
haven't
think
changed that.
I think I can see Toby there. Toby is one of the doctors from Glenfield currently.
Okay.
And Tamasha's there. Tamasha can add on.
Well, if you would like to tell me, then feel free. Richard's going to join in at some point and give us a talk, but he hasn't texted him. Does anybody else have anything to say about it? Anyone else texting Richard?
Do we have a time for the CTs? No.
Go on, Jamie.
I think it'd be interesting to look at what they were actually transfusing and whether they'd actually had 1 to 1 to 1, and whether that's changed. The products that we give over time has changed. I wonder if we'd have done the same study maybe 5 or 10 years ago, whether we'd have seen the same lack of difference.
So I think so these studies were done on patients who already had the MHB started on, and they try to use these study tests to identify what are the factors we need to transfuse. But more of the patients have received plasma and fibrinogen earlier when compared to the CCTs.
Yeah. Did they look at tranexamic acid administration as well?
No, I don't think so, because if you look at the CCT groups, they didn't receive the TXAs at all, but they have received TSA as a part of the MHP protocol.
Okay.
98 to 94, 94 versus 98% received TXA before they started looking at the demographics.
I think there's been a real recognition over the last 5 to 10 years that we need to give more plasma and platelets. So in a way, it's good that there wasn't so much of a difference, because perhaps our practice has already changed for the better.
I suspect it has, to be honest.
I think it needs to be the practice needs to be in the hospitals that don't routinely give 1 to 1 to 1, because your biggest benefit is going to be on the ones that haven't already given all the products. Then maybe trying to cut down, because here trying to get, they only give you FOP and platelets and cryo if you ask for it. Whereas at Nottingham, it just comes.
Yeah.
It gets given.
It does come for the, if you can't say it's a major hemorrhage, then it will send it automatically here. But usually,
When I've called for it, they're like, "You sure you want it?"
yes, I'm sure. No, not on the floor. Yes, I'm sure I want it.
We still get an awful lot more red cells than we need before we get any kind of clotting
Yeah,
stuff.
true. Yeah, it takes a while for it to come, isn't it? Cool. Richard said he'll be in a couple of minutes, so we'll come along at some point. Like we're waiting. Yeah, they're here. Yeah, thanks, man. You won't make some.
Oh, yeah.
Does anybody know of any studies of TEG or Rotem use in the obstetric population?
I'm sure there are. I haven't looked at them, to be honest. Your presentation, you'll make to have those.
Find someone else to go with it. I think we'll go then.
Sorry, there's lots of doom and gloom chats to have. So. Shopping bleach.
It's unmuted.
Hi, Zoe. Sorry. Hi. Just to let you know, Richard is just logging in from his office.
Awesome, thank you.
So it'll be about a minute.
Yeah, he has texted me, so I know he's coming.
Sure.
Hello, can you hear me okay?
Yep, hello. You're right.
Hello all, fantastic. Are you ready for me now, or do anyone need any more time? No, that's good.
Ready.
Okay, so I'm just going to talk a little bit about, once I can find it, let me get it. Hopefully, this should work. Can everyone see the slideshow? Excellent. Oh my gosh, it's actually all worked. This is brilliant. Hi all. For all those that don't know, I'm Richard Porter. I'm one of the intensive care doctors based up at Glenfield. I'm also, for my sins, a medical examiner, and I'm just going to talk today a little bit about sort of coroners, post-mortem coroners, and what needs and what doesn't need to go to the coroner. So a little bit of thought about what happens once someone's passed away. So just to start, I can't see anyone, but I assume you can all hear me okay. If we start with saying, when does a coroner have to look at stuff? So I'm going to talk about the duty to investigate and what deaths. That doesn't mean to say that duty to investigate is a step above reportable. So duty to investigate is that if we tell a coroner is made aware that there's a body within their jurisdiction and that the coroner has reason to suspect that the patient's died of violent or unnatural death, the cause of death is unknown, or the deceased whilst in custody or state detention, then the coroner is mandated to perform an inquest. So that sort of gives you an idea of the sort of deaths that the coroner wants to know about. But even if you report on suspicion of those things, the coroner doesn't actually have to investigate. So from our point of view, what we really need to think about is what deaths do we need to let the coroner know about and see whether or not they decide their duty to investigate is triggered. So we need to review a death to the coroner when we know or have a reasonable cause to suspect that the death followed in any of these criteria. Occurred as a result of poisoning, the use of a controlled drug, medicinal product, or toxic chemical. And that can be even a drug that's not thought normally to be toxic. So, for example, if someone's died as an infection, but they've been on chemotherapy, that's knocked out their immune system. That'd be as a result of a medicinal product potentially contributing to death. A more obvious one is as a result of trauma or violent or physical injury, whether inflicted intentionally or accidentally. So if someone trips at home, falls, breaks their hip, comes into hospital, and then ultimately passes away as a result or dies as a result, contributed by that hip fracture or the fall or the illness, then that is there. Related to treatment or procedure of medical or similar nature. And again, this is the one that often gets most people concerned. It's not necessarily admitting that anything's been done incorrectly. But for example, if someone dies as a result of complications following elective surgery, it needs to be reported to the coroner, but does not necessarily mean that anything has been done wrong at all with the surgery or whatever treatment has been undertaken. In fact, our coroner often looks at those. If the family are not concerned, it was a recognised complication of a procedure or medical treatment. She'll often do those as a paper inquest. And so you'll report it to the coroner, they'll close it with a paper inquest, and you'll hear nothing further. Self-harm needs to go to the coroner, whether or not that was intentional or otherwise. And that does include a failure by the deceased person to preserve their own life. So again, needs reporting to the coroner. Someone who's got severe self-neglect that may have contributed to death needs to go to the coroner. She may decide not to investigate, but it's one for them to decide. Anything that could be attributable to course of a person's work. So our most common one with that would be asbestos, or occurred as a result of a notifiable accident, poisoning, or disease. Although that's, I think, been taken away in the recent. She's not as keen to know about notifiable diseases anymore, but it still sits on some coroners' referral pathways. And again, she talks about neglect or failure of care by another person. And the final one is otherwise.
Yeah, that was my favorite.
Hello, sorry. Sorry, someone's come and gone a little bit. Hello.
I can hear you.
We hear you.
Notified. No, as I say, with a notifiable disease, they absolutely don't need to go to the coroner since COVID-19. It's interesting. Some people say, but COVID-19, for example, was notifiable for a while. That doesn't need to go to the coroner, and she's not concerned by notifiable diseases per se going to her. Our coroner, certainly within our jurisdiction. It depends on the nature. So, for example, gastroenteritis caused by food poisoning, she'd be interested in if it was caused by, say, for example, a failure to take proper precautions in preparing food. If you see the sort of subtle difference there. Anyway, again, occurred as a result of neglect or failure of care by another person or was otherwise unnatural. My final slide on this before I show you a little video is also occurs when the death occurred in state detention or custody. So anyone who is under a section or within police custody or within prison needs to go to the coroner, but this absolutely does not include dolls. And the other one is when you basically have not had a attending practitioner attend the deceased within 28 days prior to death. Interestingly, an attendance would class, a video consultation would class an attendance, but a phone consultation wouldn't for the coroner's perspectives. But it's unusual for any of our patients not to have been seen by any medical practitioner within 28 days of death. Certainly not for the night times, or when the identity of the deceased is unknown. Oop. Someone's just shared a screen. See if that works again.
You come back, so it's fine.
And I'll resume on slide 5. Have I come back online? Key thing to remember, if the death is due even in a small part to being a reportable event, the death itself is reportable. More for the medical examiners, when we're thinking about death related to a medical procedure or similar nature, useful questions to think about, and you'll often get asked is, would the death have occurred sooner or later if the intervention had not happened? Did anything go wrong? Are any allegations being made? From our perspective, Mrs. Mason expects us, from a medical examiner point of view, not to refer cases she would not wish to investigate, but sometimes that requires a degree of explanation to the registrar. And an example of these cases are, for example, the ruptured AAA. They go to theatre. There's a salvage attempt to save the patient, and unfortunately, they don't survive as a result of the ruptured AAA. What our coroner would more than happy be is that the attempt to go to theatre was one to purely attempt to save life. It was a salvage procedure, and the procedure itself hasn't directly contributed to death. It's as a result of the underlying natural pathology, assuming the ruptured AAA wasn't secondary to someone stabbing them in the abdomen, but obviously. And this is sometimes that we have to think about a little bit, is the coroner's office will not discuss cases directly with the certifying doctor anymore without ME involvement. And what the coroner's officer might ask you to do is to think to what is your best knowledge and belief when you're thinking of a death certificate. So if it's a slightly uncertain one, is can you think of a reasonable cause of death for this patient? I've got some case discussions coming up, but let me just see if this video plays first, and I want you guys to decide how many of these cases you would have referred to the coroner, just as a little bit of light relief. Bear with me. Gonna have to try and get it to load now. Right. Okay, if you just watch this video, and then you can tell me how many of these cases everyone would refer to coroner, just to pass a little bit of time. I'll just pause it. Can everyone hear the video when it plays the music?
No, I can't think it's unmuted.
No.
Sorry?
No.
It's not playing the sound across, is it? Oh, that is annoying. Not at all.
Somebody if they got their head bitten off by a bear.
Well, that's, yeah. Lots of dumb ways to die, this video, but you can't hear the song and the music playing. Should I put closed captions on?
Yeah, could you? Yeah.
I'll do it that way then. Right, let's go. Well, that was slightly disappointing. You couldn't all hear that, but I don't know how well the closed caption has worked as well. But ultimately, how many of those cases didn't need to go to the coroner then?
We decided most of them did.
So the one who got bitten by a snake, no. The one who got eaten by bees, no.
Really?
Well, he picked a beehive up and dropped it on himself. So presumably that's anaphylaxis or death by bees. I mean, it's an obvious cause of death that was self-inflicted by picking up bees.
Yeah, it would do, I'm afraid. We've had anaphylaxis from a wasp that we've had to refer to the coroner. She chose not to investigate, but she did want to know about it.
Fair enough.
It's a death from an animal bite, is the way she looks at it, which is unnatural.
And you get you bitten by a snake as well. Would that
Oh
be
yeah,
coroner?
definitely. That's a death from an animal bite. Is that a natural cause of death?
Well, it needs to be bitten by a snake. Depends where you live. If you live in Loughborough, probably not. But if you live in, like, I don't know, Thailand, probably yes.
I expect the Thai coroners might not accept snake bites then, but our coroners certainly do. So you would want to know that as well, I'm afraid.
But like being run over by a train, I reckon yes. Being run over by a bus, falling off a roof, yes. Being shot dressed as a moose, yes. I can't think of the others. Chopping off for another reason.
Yeah, beaten up by a drug dealer. Yeah.
Most of them seem to need it.
I would agree. Most did probably need to go, I'm afraid. And I'm sorry, Mike, I definitely wasn't going to step in to sing. That would be a reason to refer to the coroner in itself, I suspect.
What? Eating cheese? What?
Say again?
We didn't figure out why the one that looked like they were eating cheese died.
That was a 2-week-old unrefrigerated pie.
Oh, okay.
But it didn't quite come across perfectly in the
Again, self-inflicted, probably.
Self-inflicted. Yeah, that one you might get away without, possibly. But yeah. But now the way I looked at it, I thought most of them did need to go via a coroner. It'd be impressive to get a selection of some of those round here, but it was ultimately all from an Australian railway safety campaign. It's worth looking up the video and listening to the song when it's actually sung and try and see how long it stays in your head for afterwards. But it is worth a little watch. It's a shame it doesn't work on this system. I've just got a few more slides and stuff to think about. Review for slide 10. And then it's more of a discussion rather than me just chattering away to you. So I will bring out a case for you. And is that sharing okay? Right. Answers to that one. Who would refer this one to the coroner and why? Or not and why?
Must have been there.
You could just speak. Richard, can you hear me?
I can now, yes.
So any occupational exposure is a referral.
Yes.
And most mesothelioma is related to occupational exposure, but not necessarily.
Yes.
So I don't think mesothelioma in itself is a referral if you can't link it to occupational exposure.
You would have to have a suspicion of occupational exposure. If there's no occupational exposure, then no, you wouldn't have to refer. It'd be a natural. Again, though, it's rare. The question coming from this is why haven't we found out where his source of asbestos is and what's it come from? And the question about the office would be, did the office have any building works done at any point which exposed them to asbestos exposure or anything? It's rare not to refer, but again, the coroner often would investigate for us, looking at whether there's an occupational exposure rather than us. But if you're absolutely certain there's no occupational exposure, then no, it doesn't need to go. But in most cases, we would refer because I suspect the investigation as to any occupational exposure would often be done by the coroner's office to more details than we would be able to do within a hospital environment. Does that make sense? But yes, ultimately, if you've got an absolute cause and you can say there's no occupational exposure, no, it doesn't ultimately need to go. We would normally refer just if you've got any doubt whatsoever or any sort of history, because it's unclear as to where it's come from. But yes, and again, if there's absolutely no exposure to it, then no. But My understanding is mesothelioma is always caused by asbestos exposure. It's effectively pathognomonic. So you've had some asbestos exposure in your life. If you can't explain it and as a non-occupational cause, I'd be reluctant not to refer, I'm afraid. But I don't know what. Again, that's a varied system.
If you work in an office, you'll see it's less likely, but
It does. It does. Mike, you've got your hand up.
I don't know if you took this from a case that's gone through the MEs, but I referred a case like this, I think, in my first year of being a consultant.
Yeah.
With absolutely no exposure whatsoever. It went to the coroner for just to be further reviewed, despite it being, and it turned out that actually it was exposure to she was, I think, in her 40s, 50s, but it was exposure from her father, who was
occupationally
asbestos, and he brought back his overalls, and she assisted washing, which had asbestos fibres on it.
Yeah, that makes sense. Again, different, not this one, but yeah, I would agree. I think you'd have to be absolutely certain there is any history of any industrial exposure, and I would say within our remits of being able to investigate deaths, we probably haven't got that degree of scrutiny and certainty. So personally, I would refer to the coroner, but I can appreciate there are others who might not if they were absolutely certain there's been no industrial exposure. Okay. Any other thoughts on that one, or should we move on to the next? What does everyone think here?
Refer. So fall at home.
We've got, yeah, what does everyone think?
We discussed it with the registrar, but she's fallen at home, so it's related to trauma at home. She's fallen and broken her leg, and her death is directly resulted from that. It will indirectly resulted from that.
Although in this case, we've got no history of a fall. She's just gone off her legs, complaining of pain in it.
Okay.
We don't know she's fallen. We presume she has, I agree, but yeah.
If she'd fallen, it would be clearer.
It would, wouldn't it? I mean, to be honest, the other question is, how do you develop a fractured neck of femur without falling? I mean, the question that we always get thrown back at us on this one, if it goes on to the next slide appropriately, let's just see, is that.
So if you can find any kind of metastatic cancer, then you can just say this is it's just a pathological fracture secondary to that. And then the operation is, I mean, a lot of people regard a fractured neck of femur operation as palliative, don't they? So, no, but I mean, it is a palliative operation because the life expectancy proposed at NOF is actually quite short. So, yeah, so.
I would agree. It's always, again, as with all these cases, it's difficult. Our coroner is quite reasonable in her approach in terms of she doesn't want to refer cases that we don't think she'll need to investigate in any way, shape or form. She sometimes, the reason we refer falls is she feels it's a duty of her to double check whether that fall was a natural fall, i.e. was it a trip, or was there any evidence that she was pushed? And again, that's not for us to decide. In this case, it's a little bit more grey. You've got someone who's gone off the legs. If they did have a pathological fracture, that can just occur with walking around, can it not? And the fact that she's had surgery, well, you could argue the fact that she's had the fracture as a result of pathology, the surgery probably prolonged life rather than shortened it, or certainly it didn't hasten death. You could possibly argue in a really barn door pathological fracture post-operatively that hasn't affected the outcome, you don't need to refer. But again, most people would probably run this past our coroner given the history and the uncertainty. But again, it's open to debate. I personally, I think if I had a very strong history of pathological fracture, no evidence of any fall or trauma, and that was from a very good history, and the fact that we're content that the surgery here was done in an attempt did not hasten death, then I wouldn't refer, but I'd have to have lots and lots of of confidence in the history and the story given to me. If there's any doubt whatsoever, then again, it's nice for us to try and investigate deaths, but again, we're not really set up to do that outside of what we've seen directly or what a strong history is. It just reminds me of another one we got is when we got told there was evidence from different ones, to be fair, but evidence from a CCTV that the patient had collapsed and looked natural, and we think they died and then came in dead, and we were asked could we issue it as a strong history of cardiac disease and an ECG done immediately on a brief ROSC that showed ischemic heart disease. Could we issue as ischemic heart disease? The answer was probably yes, but because there was an CCTV, the argument we got used that we had to refer was that we are not trained in interpreting CCTV. Therefore, that needs to be looked at separately to make sure that the natural looking collapse was as natural as it looked at and someone hadn't wandered around the back of him with a stick and knocked him down or something. But that's one of those key ones. What do you think to this one, guys?
Yeah. Richard?
Yep.
So initially I thought, yeah, that's fine, he's got disseminated malignancy, but then there's that little line, is that deliberate 4 days after admission?
Yes, it is deliberate.
He was then given anticoagulation 4 days after lying in a hospital bed and then developing a DVT.
Yeah.
So if I'm assuming if he had Alpar on the day he came in, this would just be someone was died of metastatic lung cancer.
Mm.
But the DVT, he was in hospital 4 days without any anticoagulation. Prophylactic anticoagulation.
I think you've got multiple issues here. One, you've got a definite history of a fall that led to the fracture.
Yeah, but it's because of
even though it's pathological. But would you have broken his leg without at that time and place without falling? With the pathological have fractured it anyway, it's probably difficult. B, yes, in this case, one could argue that if you've diagnosed a deep vein thrombosis and you haven't treated it after diagnosis within a certain period of time, has that increased the risk of death from pulmonary embolus within the 24, 36 hours? Again, it's always really difficult. Are those questions do you think we should be answering as clinicians, or do you think those are questions that need to be answered externally? So my first question is, do we think that if this patient hadn't fallen, would he have died in the time and manner in which he did?
No, we're not.
Even with the pathological fracture, in this case, you've got a trigger event that's unnatural that led to the admission.
But if he wouldn't have fallen, though, would he? So he's had a pathological fracture, he's fallen.
Mm.
But then you've still got to explain the fall.
Yes.
And then plus that, you've then got a failure of care, potentially, which probably needs at least some kind of root cause analysis, because I think all the DVTs do, don't they? Or the Ps that result in death do.
Certainly.
And then the certificate, what they've suggested on the certificate, I would say is incorrect. It's incomplete, not incorrect.
Yes, I would agree completely. I think at the very least, you'd have to argue the fracture here was contributory to death and the fracture occurred as a result of fall. So I'd be probably putting it in part 2 if I was looking at that. And I'd agree disseminated bronchial, or you could do down the route saying disseminated bronchial carcinoma, fall leading to a pathological fracture of such and such, leading to the deep vein thrombosis and pulmonary embolus. So I think in the cause of death to be totally complete, you've got to have the fall and the fracture, which by definition moves it to a coroner's case. And B, there are some questions that are raised about the medical management here as to whether the death had occurred as and when it did, had they administered anticoagulation earlier. Again, always very difficult. From my perspective, do we really think 24 hours more anticoagulation would have prevented P in this case? I'm never convinced by that, but again, that's not really for us to answer. But what might happen with this case, if you refer it to the coroner, she might phone you and ask you those questions, and then you're very much entitled on the balance of probabilities to give your opinion to the coroner, and she can decide whether or not to accept it. But I think this one would be a coroner's referral. How about this one? Zoe, you've changed somewhat.
I've hatched like a caterpillar into a beautiful butterfly.
What do people think about this?
This is something we see not that uncommonly over here in the Royal. So the questions are related to chemotherapy, the timing of the chemotherapy, whether that could be involved in his immunosuppression, which has led to the fungal pneumonia, and whether this is all contemporaneous, which it probably is. So our coroner, I believe, likes to know about the chemotherapy immunosuppressed deaths.
If we think it's contributed to death, the times we possibly could get away without referring something along these lines is if we were convinced that the chemotherapy hadn't particularly added to the immunosuppression that had led to death or contributed to death in this case. So if we think the death was purely due to progression of the acute myeloid leukemia and not related to chemotherapy, she would be happy for it not to be referred. But to be honest, I would always suggest that if you've got chemotherapy and that was recently, and you've got worsening immunosuppression, which often is a result of chemotherapy, I would suspect, then this one would need to run past. How about this? This kind of answers it for you, exactly as you were saying.
I'd say that the what if is definitely a referral. The only way it could not be a referral is if the myeloid leukemia had the chemotherapy 10 months ago and everything was fine subsequently, and then they died of pneumonia. Coincidentally, which would be unfortunate, but not impossible.
I would agree with that, absolutely. Most definitely. The case sent to us from our coroner. So one question would be, do the family members have any influence as to what is written on the death certificate?
Richard, I can't see how you can not put HIV infection on the certificate because it caused the condition. And I'm very sorry that they feel embarrassed, but you know, he's dead.
Absolutely agree. It's one that occurs once or twice a year. We do get asked to take things off death certificates, and the simple answer, and our coroner is very supportive of this, is if we feel as medical professionals it needs to be on the death certificate to truly represent the actual cause of death, then it needs to be on the death certificate. And the family, we can, if they're going to be unaccepting of the death certificate, we would refer to the coroner. That's one of the reasons to refer to a coroner, is that the family don't accept the cause of death, but ultimately it should represent what we believe, to the best of our knowledge and belief, what has contributed to death, regardless of what the cause is and what the family think about the cause. It was not uncommon during COVID to be asked repeatedly to take COVID off the death certificate. But when it was clearly a COVID pneumonitis that's caused death, we had to write it on the death certificates.
My only question about that death certificate is AIDS still a word that we use for death certificate? I mean, does that word need to be there because it's unmanaged HIV?
No, you absolutely don't. Again, with a death certificate, it's the 1C that's important, and the 1A, 1B, for example, in this case, is less so. Ultimately, the thing that's caused the death here is the presence of an HIV infection. And no, you wouldn't need to put AIDS down. Pathologists still quite like it for some reason, but no, absolutely not. You could take the AIDS out, and just 1B HIV infection leading to 1A cryptococcal meningitis would be entirely acceptable. But yeah, natural cause of death.
It is a natural cause of death related to the HIV infection, but what is there any issues around the HIV infection event?
There you go. Good question. And this, when you speak to the family members, this is what they raise.
No, Richard, it wouldn't. If they feel that's the case, they could report into the police.
Yes, but would we have to do anything different from our perspective?
I don't believe so.
We would have to report to the coroner.
Would anyway? Oh, I see what you mean. Yeah, I see what you mean. Yeah. Yes.
Yeah, it's become, there's now a reason. So our threshold for referral is actually quite low for coroner referral. We don't have to have anything other than a suspicion that something may not have been quite right. And if it's a deliberate infection, then the coroner can decide what to do next. And yes, they would report it to the police themselves, I suspect, from the coroner's side. They would ask for a police investigation in this case, if they deemed it to be plausible. And that occasionally does happen. If you she refers a couple of her cases every year to the police. But yes, absolutely. And this one, guys and girls.
I thought you did drugs.
No,
Who was that? Sorry.
no, because I don't know, like, no judgment on lifestyle choices, but his virus was directly, you could kind of link it to the fact that he was an IBD user. So yeah, he got he got hepatitis B virus and that ultimately because of the thing he had done.
Ultimately, yep, you're right. Our coroner is not hugely interested if it's a lifestyle choice of the individual. Hence, for example, we don't refer alcoholic liver disease that has led to death due to chronic alcohol abuse. So yes, and hepatitis B no longer is an automatic referral to the coroner. You can now issue as hepatitis B without coronial referral. But as of all these slides, because they were there, there's a few what ifs.
Definitely.
Yeah, that changes it somewhat. Interestingly, we've had an interesting case where the cause of infection occurred in Australia from a contaminated blood product in Australia, and our coroner is still interested. So it doesn't matter where that occurs. So if it's occurred abroad, our coroner is still interested if the source of infection is still believed to be medical administration of a contaminated blood product, regardless of where or when it's occurred.
Richard?
Yes?
There's been a drug user takes drugs and stops breathing and dies of cardiorespiratory arrest because of the dose. Is that a coroner's referral?
It is, because the death by definition then is accidental, and acute toxicity is a reason to refer. Chronic toxicity isn't. So, for example, the example I always use is alcohol. If you chronically abuse alcohol and then die as a result of alcoholic liver disease, be that, say, for example, even a varicose bleed or anything else, that doesn't need to go to the coroner. If you die from an acute alcohol intoxication event, so you've drunk so much alcohol, you vomit, aspirate, and die from aspiration, then you need to go. So anything that's an acute intoxication event is known as poisoning, and that has to go to the coroner. So yes, an overdose of opioids that's cause of respiratory arrest leading to death would be a coroner's referral, as it's an accidental, potentially accidental death, or an assumed accidental death. But what you don't know is if your mate's injected you with the drug to stop you breathing, or something else has happened.
There's been a huge compensation claim payout about contaminated blood products recently, hasn't there? So
there is, and again, so if anyone's got any suspicion, I'm sure it will be raised as part of the family discussions. But again, most people know if it's done as a result of a contaminated blood product. But yeah. How about that one?
I'd say probably no, because there must be a certain element of community transmission of hepatitis B that you'll never, ever get to the bottom of.
Absolutely. I think our coroner would be, in the absence of any history or medical issues or even the acute drug abuse issues, then I think she would be uninterested. So yeah, I wouldn't refer in that case. But yeah. Only got a few more, you'll be pleased to know. This one. That's a yes for you, Martin, is it? On what grounds?
I would say this, if somehow this man came into to us, because he is clearly, he has a huge amount of safeguarding concerns. on the basis of, I mean, this sounds like a vulnerable man who is, yeah, I mean, just, I don't quite know the right words to use. I mean, but that is elder abuse.
Potentially. You certainly got you've got concerns. You've certainly got concerns about neglect here, and it's likely that this admission would raise safeguarding concerns on admission to hospital regardless. The answer is actually it's not as clear cut as yes. I would probably refer that, but the argument back would be, especially if they spent a longer period in hospital, is what is the death itself natural and related to the neglect or the safeguarding issues? I think if they've come in that state and died shortly afterwards, it becomes more obvious a yes. But sometimes our coroners, to be honest, I think if there's any doubt, you would refer to the coroner. Certainly, if there's going to be safeguarding issues raised, but there are sometimes our coroners. She thinks the death is still natural, despite what care has been received. She's not always 100% interested in hearing the case. So if someone's had a fall, no injuries, brought in and dies of pneumonia, and the thought was the pneumonia had occurred before the fall, for example, she wouldn't be interested in those cases, but would be if there was other issues. Does that sort of?
I was going to say my issue with this was if it was a 70-year-old man being looked after by his demented 70-year-old wife and came in like this, then no.
Yeah.
The fact he's from an organisation that is supposed to be looking
Yeah.
after. That would just be my argument.
I mean, the other argument is even if he's been looked after by his wife, is that a failure of the social services to provide adequate care and support?
Yeah, so safeguarding concerns which go through but probably not a coronial inquest.
Yeah, it's difficult, isn't it? I think someone who's got multiple bruising, a black eye, a deep pressure sore in someone who is clearly unable to care for himself has come in that state. It would be hard to say actually the neglect hasn't contributed here. There's certainly a safeguarding issue, and I would personally refer, particularly with it being from a nursing home. But yes, it sometimes doesn't trigger a coroner's investigation following referral because she says, "Oh, actually, despite all that, I don't think the death is related to the neglect per se." And it's a natural death, but it is sometimes worth, again, asking for an external organisation to investigate rather than us making the full calls. But it can be, sometimes there is a bit of flexibility in these referring. I think in this case, I would definitely refer. But again, if it was slightly less cut and dry, then it might be one way you'd think about whether or not referral is needed and the death is due to something else. But yeah. What about this? 95 and terminal cancer.
Circumstances, Richard.
Sorry?
The same circumstances.
Yeah.
Yeah.
Just a 95 with terminal cancer that's admitted.
No, but with all the previous condition you mentioned in the last case.
It's the same case. It's just instead of a 70-year-old demented man, it's a 95-year-old demented man with terminal cancer from a nursing home.
I think if your concerns for the first referral are neglect, then it doesn't make a difference, does it? I'd refer.
It doesn't. No, you're right. Absolutely. Sometimes age and underlying diagnosis make a difference. In this case, one would argue that, yeah, I would agree. I would still refer if we've still got the concerns about the safeguarding and neglect. Definitely.
Is it a yes?
A yes. Why would you refer this one?
Especially if there's no sign that she hasn't been followed up after she's had this lump removed. It's been 5 years, and it is quite likely that the Mets come from the previous breast cancer. There's a failure of care within those 5 years.
Fair enough. I think that's not unreasonable. My suspicion with this one is because we've got a clear natural cause of death, we would probably report it to our coroner. I suspect she would decline to investigate, but ask that the trust looks at it themselves. But yes, I would certainly run this one past our coroners because, again, it doesn't sound like there's been adequate follow-up, and the fact there's no histological report is a little bit concerning, isn't it, as well, in this case? But yeah, I would run that one past, but I suspect she would decline to investigate and ask us to investigate through the trust in this case. But yes, it was one that we'd have to ask her. This one.
Richard,
Yes.
as a rule, I mean, anyone who's under psychiatric care or has mental health issues, generally speaking, you'd consider referring to the coroner. I don't know if that applies if it's a compulsory and chronic admission, but maybe
Yes. So,
maybe
you're right.
it's yes,
Yeah.
she's in a psychiatric ward, so by definition, yes.
Except the only thing I'd say for that one, she's voluntarily admitted. She's not under a detention, state detention, as it were. So that will take away the mandated referral. But it's more the other points here. Could one argue that starvation within or dehydration within a hospital environment is something that should really go on a death certificate without at least a coronarial involvement?
Is that neglect?
Potentially, but again, if she had enough capacity to refuse to eat and drink, then potentially not.
Did they comment on capacity? Because she's in a long-term psychiatric hospital.
They haven't said. But again, the thing that worries me with this one, this is a patient who has got no medical problems other than psychiatric illness, refused to eat, refused to drink, and then refused to allow medical examination, and then just faded away. My understanding is they can mandate feeding, or in that case, one would be concerned about the capacity issue in someone in a psychiatric illness who's refusing to eat and drink without taking any further steps. So I think the fact that this is a death from potential and natural cause, i.e. starvation or dehydration, not due to aggressive medical pathology, then I would be very concerned not to refer this one to the coroner on the grounds of the fact that this could be, it needs to be looked at, I think. I don't know what everyone else thinks here.
64 with intractable and treatable psychiatric disease, and you decide I don't want you to drink anymore. Not sure I would force that person under duress to have food. And
it's
like
like
you can't fix it. Or she can have the peg feeding tube the rest of her life, or you can. I mean, you can't force. I mean,
it's difficult though, isn't it? I mean, my question is, if you've got severe psychiatric illness, at what stage? There's no comments about capacity here, is there?
I feel like you need a bit more context, like
a bit more context.
A bit more of what's the family situation, how much of the family involved, would they have wanted to intervene in the situation, best interest, it's a bit.
What I've seen usually happens is that these patients, they get transferred to the Royal, they receive IV fluids and all that, and with some sedation, because they're usually very aggressive and they don't want any treatment, they come to the brachythium to get some, for example, electroconvulsive therapy, and then return back to the Royal to receive the IV fluid until they start improving. Yeah.
Okay. So it's a yes there, Richard.
Sorry?
It's a yes then, we think, yeah.
I would refer that one definitely. Yeah, I think there's enough grounds for me to be concerned enough that I wouldn't be happy to issue that as a natural death certificate. Dehydration and starvation, you can't issue a death certificate as it's not a natural cause of death per se, although it can be the natural endpoint of a disease process. In this case, I'd be concerned with the psychiatric history and what could be claimed as an unnatural cause of death without a huge amount of information. I think the coroner would probably need to look at this one to see whether there's any further investigation warranted. She might decide after investigating that the patient had sufficient capacity to refuse to eat and drink, and therefore the death is natural and doesn't require anything further from her perspective. But it's certainly one I would refer. The way she tends to look at these things a little bit is the death a result of the end stage of a natural process? regardless of sort of time frame. So, for example, she's very happy that an acute myocardium can cause a natural death very, very quickly, or something such as esophageal cancer may cause a natural death over a much more prolonged period of time. But what she wants to look at is the end stage, the results of that natural process, or is there any unnatural or any elements that could be considered a little bit iffy, for want of a better word, within the death. And in this case, there's certainly some elements that you think are a little bit potentially iffy that might just need coronial review prior to doing anything further. Just got one or two last ones to do, bear with me. And then thank you very much for your time. And there you go. So nothing to do with
Where did the
bronchopneumonia come from?
It's the answer to everything.
That's the coroner's answer to any natural death certificate that they want to investigate.
Fair enough.
And a few times I've done it. Oh, that's not flashing up the stuff. Let's see. There we go. What do you think? Yes or no?
I think in the context, Richard, I think 4 hours is pretty rapid, isn't it, in A&E now?
So in current climate, would say it's exemplary care, but okay.
Question is, do you think the delay contributed to the death?
So the fact they've issued it, so the question I'd look at it, do you have grounds to suspect the delay has contributed to death here from that information provided?
Well, I don't know. If 4 hours, I mean, people sit at home for hours and hours, don't they? With
yeah.
Once he's diagnosed with an acute MI, he should have been sent immediately to CCU for treatment.
Yeah.
So 4 hours was a delay that could have been avoided.
If we make it more realistically and call it 14 hours in the current climate, what's your thought processes?
Yes, that was substandard care.
Okay, so would you refer to the coroner at this stage?
I have to say no. I think it's a natural death. It's just not been managed very well, and the hospital is investigating itself.
Okay. Always a tricky one. So the other question I'll ask is there a time frame to refer to the coroner after death?
No.
I thought you'd prefer any time.
Absolutely. So you subsequently discover something that requires coronial involvement. If Dr. Pepper's not on duty and you're not going to let sleeping dogs lie, you probably should. Yeah. In this case, it possibly, given the fact it's been looked at as an SI and a root cause analysis initiated, you could argue it two ways. You could wait to the results of the investigation, and if they felt that deficiencies in care contributed to death, refer to the coroner at that point, or you could just write to the coroner and say, look, this is what's happened. Do you want us to refer at this stage, or do you want us to wait? I think if there's been a significant concern raised, and it's possible that a delay in treatment, you've got grounds to suspect, have got a reason to have contributed to death, you probably are obliged to inform the coroner. But it is sometimes very difficult. And again, our coroner is not unreasonable. She is aware that sometimes our M&M processes might suddenly find something that we weren't aware of initially, but she would expect to know if we do find something that we think required coronial involvement and is appropriate in terms of and would be appropriate potential for coronial investigation. So yes, there's no time limit. You're absolutely right. And in this case, it's a common question thrown out. It is a difficult one, but I would personally say that given the fact there has been significant concerns raised, and it looks like there might be a concern that the delays in treatment did contribute to death, then it probably should be at least run past our coroner's service.
The way things are at the moment, I hope she's got a big inbox.
You've got to have it as a cause. So most of the cases probably don't contribute to death, do we think? Or yeah, but yes, if it. Our coroner is currently concerned about the number of referrals she's getting. Yeah.
Are they concerned?
Well, she's she's concerned. What she doesn't want us to refer, and what she's less keen on us to refer, is when we're not entirely sure of a cause of death. But i.e., if we think we can issue a natural cause of death and we've got a reasonable grounds to suspect that's the cause of death, rather than refer to her as unknown, what do we think, or we're not entirely sure, she prefers us to issue as what we think is the most likely cause. So that's what she gets concerned if we're referring people, because we're a little uncomfortable about issuing the most likely cause of death, but there are times when we absolutely can't. She is interested in cases where there has been a delay, but what she looks at is whether or not that delay, how likely is it that a delay or an issue with treatment has contributed to death. If she says it's arguable that it didn't contribute to death, she's much less interested in if someone turns to her and says, look, this is really clear. Had this guy had this, there is a much better chance now that he would have been alive, and she would want to know about those. This one, I think, is, I agree with you, a very grey area. And again, I suspect an increased number of coroner's referrals due to delays in treatment would, again, help highlight the current pressures the NHS is under.
Just a question. What do you think the situation would be different if the 4-hour delay wasn't in the emergency department, but it was waiting for an ambulance, and the outcome was the same via the hospital?
Again, if we think the delay in ambulance contributed to death, then that's a delay in medical treatment, and that should still go to the coroner, even though it's external to UHL. Even though, again, it's always difficult, and I appreciate what you're saying. The level of care we're accepting, I think, feels in terms of this is different to where it has been in the past. But it's more of a legal aspect rather than, per se, a moral one, I suppose, is the way I'm looking at it. But ultimately, if we think there's a delay or an issue with treatment that has contributed to death, then we should refer to the coroner, regardless of time limits and all the rest. If we think it hasn't, then we don't, or we don't think it's made any difference to outcome, then we don't. But if we are fair, we've got grounds to suspect that actually, if this patient received more timely treatment, they may have survived, then ultimately we should refer. But it's not that common we see those cases, to be fair. We normally feel that the progression to death would have happened regardless of treatment interventions in most cases. But again, that's something to think about. And I've just got any more comments on this one? I appreciate it. Sometimes there's no very good answers, I'm afraid. It's with the coroner, it's all about legal aspects versus other aspects, and when her lawful duty to investigate is triggered or not is where she tends to come from, rather than what we feel is often what's appropriate to refer or not, per se. I'll give you the what ifs as they appear. Oh, they're not going to. There we go.
Immunosuppression, yes.
Yes, good.
I would say 1 month, yes. Others, no.
Okay. Bottom line is we would tend to refer these mainly because if we write an accurate cause of death on the death certificate and send it off to the registrar with this on, it gets bounced to the coroner regardless. So we just tend to refer a brief referral just to close the loop so it gets approved at the registrar's office. Really difficult. This is an example used across all the medical examiner training as an appropriate natural cause of death, because you could argue very clearly this man would have died a long time early. He'd have died a lot earlier had he not had the intervention medically. But ultimately, our registrar officers still won't accept it if we write anything other than a completely natural cause of death on the death certificate. But the fact that this is chronic rejection of a cardiac transplant means our registrars would currently reject it without coronial approval. So we would tend to approve, even though it should be one they accept. So it's a sort of slightly more controversial one in that respect. But yeah, time frame. I agree with what you're saying, Martin. If you think it's directly resulted to the surgery or something within a short time frame afterwards, then absolutely it has to go to the coroner. But I appreciate this one is a difficult one, and we have definitely prolonged life in this case.
feels like a natural cause after an unnatural intervention.
Yeah, it's difficult.
Okay.
But one could argue as our intervention has prolonged life rather than shortened it.
Yeah.
And that's what she's often interested in. That will be the question she would ask the referrer. Do you think the intervention prolonged life? And our answer would be yes, in this case. At which point she wouldn't investigate, but it's probably appropriate to refer. As again, even though it's officially not, you could put it through the thingy, but our registrars would reject it. Just some few cases just to make you all think a little bit, but yeah. And again, it's not always very clear-cut answers, and these get discussed at medical examiner days where there is a multitude of different opinions between all the different medical examiners, and more interestingly, a difference of opinions between different coroners' jurisdictions as well. So not all coroners are the same about what they want to know about.
I suppose this last one is a natural death, a very weird situation, isn't it? So that's
Yeah.
You know.
And again, if we try to put it through the registrars, we've done it before, we just find they bounce back at us and it causes a longer delay and a further coroner referral and all the rest. So we decided actually it's just more simple to put it straight through a quick coroner's referral. I would suggest you write the death certificate at the same time and then just wait for the 100-day form to come through and then get approved at the coroners. And you'll be pleased to know that's all the cases done. Thank you very much for attending. Is there anything else for teaching that you need to do or hand out?
So feedback thing.
Just need to do share the feedback slide. So give me 1 second.
Oh, sorry.
Did anybody have any questions or anything? Shout out. Okay. I don't know where there's a ventilator outside. I think they're going to CT.
So show some beds when I'm just putting them in the another room.
Thank you very much, Richard.
No worries. Well, thanks all for attending and enjoy your weekends.
Well, we'll try.
The on-call super team. So.
On-call super team. Well, exactly. I'm on the. I think I'm in the EMEA's office next week, so I'll wait forward to your attendance then.
I'll be down next week.
There will be a few.
See you all soon, guys. Take care. Bye bye.